Yeah.
Good evening.
Good evening.
Welcome to St. Albans. Just a few announcements before we get started. This is our lecture series, and we do 5 a year. We have one in May that's going to be on VA benefits. That would be the 16th of May. Then we take a summer break, and then in September we have one on diabetes education. And then in November we will have one on MS. So please, it's great to see you all here tonight. Please take these into consideration in the next few months, and welcome. Okay, Beverly?
Thank you all for coming this evening. Our lecture series today is Parkinson's disease, and we have just a very dear friend and colleague, Dr. Efrain Perez-Vargas, and he's here to talk about Parkinson's disease. Dr. Vargas works with Reading Hospital, Tower Health Group, and he's a movement disorder specialist. And so,
well, first of all, thank you for having me here. I was very excited to actually get the invitation for Beverly. It's not every day that I talk to a church group or people in the community. I had quite experience before coming here. I worked at the University of Wisconsin for many years, and family got me to this area, and I actually have enjoyed living in Reading. I was kind of surprised. I was, to say the least, my wife decided that she wanted to be here. My 2 daughters live in Philadelphia, and when I said, well, these are the places that we're living close by where you want to live, and she said Reading, and I was in shock. But it has been a really nice welcome. It has been a great group of people to work with, and certainly the community has been very welcome. Before I start, everybody asked me why Parkinson's? Why made you decide to go ahead and decide to get into the field of Parkinson? I have a strong family history of Parkinson's disease in my family. My mother has it, my 2 uncles had it, my grandfather had it. So I have a really true interest in the disease and actually trying to do good to patients with Parkinson's disease. So it's pretty much endowed upon me about trying to take care of patients with Parkinson's disease. So I have a personal interest in the disorder. And that's what got me. Actually, by profession, I was an internal medicine doctor before I decided. I never practiced internal medicine. I finished internal medicine, and my mother got diagnosed with Parkinson's disease, so I decided not to practice internal medicine and joined into neurology. And here I am, almost 22 years after doing neurology and Parkinson's disease. So that's a little bit of my personal background. Everybody wants to know those questions. All my patients, when they come into the office, they want to know those questions and they never ask about it. Why Parkinson's? What are you doing here? Why this kind of rare disorders? I'm in motor neurophysiology, and that's what Dr. Gabriel and Beverly wanted to say that. It has taken me 22 years of doing this, and it's still my mother doesn't exactly know what I do. So don't worry about it. It's easy to say I take care of people with disorders of movements, and that I leave it there. I'm going to concentrate a little bit about Parkinson's disease. This is part of my academic slides, so I really shorten them down. I try to do most of the talking and try to explain in simple ways so everybody can be here and understand a little bit about the disorder and get the fear out of Parkinson's a little bit. I see some of my patients here, so they are experts in this. They really know about the disorder. They live with the disorder, so they really know even more than I do, because I would be very pretentious to know what is to say what is Parkinson's disease, because they really live it every day. A lot of the times I offer options to the patients. What do you want to do with this? And they look at me and I say, well, you're the doctor. I say, well, I don't have the disease. You need to tell me what bothers you the most. If it's the memory today, or if it's the tremor, or if it's the balance, or if it's the depression that is affecting. And we're going to talk about all these things, how the disease impact about the disorder. Just to give a couple of little backgrounds in the disorder. Actually, this is taken from Kaiser Permanente. Kaiser Permanente was one of the first HMOs in the nation. And because of financial reasons, they really keep good data about their patients. They want to see what are the statistics of the patients, where they're going to invest the money. It's not that they really want to do good statistics because of the good of the nation, but because of financial reasons, they keep good reasons. And actually, they kept track of our patients, And as you can see, as we get older, the age is the bottom part. As we get older, we have more chances of getting Parkinson's disease. This actually has changed lately, and if you look at new data of this, we're looking at two things. Patients with Parkinson's are getting younger. So people are getting younger when they have Parkinson's disease, and the numbers are getting slightly higher. And we look about this, and now that we have all this publicity, we have an ex-president got Parkinson's disease and passed away, and we have Muhammad Ali and Michael J. Fox and Janet Reno, and we even have a Pope now that had Parkinson's disease. So the awareness of Parkinson has really come up. So we said, is it because we're getting better about getting the diagnosis and diagnose these people earlier? Well, even if we take account that, we still cannot come out with the real numbers. Can't explain why we're seeing younger patients. The other component is it's not because, but also are we having longer age expectancy, and because people are getting older, we're having a chance of actually getting to see more patients with Parkinson. But it's not only that we're seeing more patients, but the population is getting younger when we are seeing the patients with Parkinson. So something is going on in the environment or in the genetics of the population that we're seeing patients at a younger age, and the population is getting bigger. Right now we have about 1 million patients of Parkinson's disease in the United States with Parkinson's disease. And we were expecting around 750,000 patients for the disorder. The other thing that we know is actually patients with Parkinson's, they're more commonly male patients. And if you take into consideration that women live longer than men, I would also see that the longevity of us is not being explained why we're seeing more patients. I've been married for 34 years, and I can tell you I can see why we die first. So actually, when you look about Parkinson's disease, believe it or not, the area of the brain that is affected with Parkinson's disease is really very tiny. It's not a big area. And when you look at the area of the brain, it's not actually bigger than the size of a grain of rice. And it's this little pigmented area here that we see. This is a cross-section of the brain that is not bigger than the thumb, this whole area. And that little area contains cells that are pigmented. And you see them there in a normal brain on that right side, that they're dark. And that area starts losing the cells sooner than we lose the other areas of the brain. And the lack of those cells is what produces Parkinson's disease. That area is called substantia nigra, or meaning black substance. So that's why you see it when you cross the brain there, you see it as a dark area, and in the left side you see a brain that is not pigmented or not dark, and that's a brain of a patient that has Parkinson's disease. And so despite you think that this disease that produces so many symptoms as we're going to see, that you think that it's really affecting the whole brain, has been affected, it's a little area of the brain that is affected. So when you compare Parkinson's disease as a patient with Alzheimer's, in which the whole brain is affected, all the gray matter is affected, the area of the brain in patients with Parkinson's disease is really tiny. Now, this area of the brain plays a crucial role in anything that regulates speed in the process of the brain. So we will have a lot of symptoms that we're going to see. Now, the first things, when James Parkinson, the one that initially described Parkinson's disease and therefore it has his name, he actually looked at 4 things that he was looking at patients, and he looked at a collection of patients in a ward, and he described 4 symptoms, and one was the resting tremor. And it's not any kind of tremor, it's the resting tremor. So when the patients look, they have this kind of funky tremor that sometimes we describe it as pill rolling tremor. So it's not any kind of tremor. We all have tremors, and if I drink a lot of coffee and get really tired after I go to the gym, I will have a little tremor in my hand. That's not the tremor that we're describing. It's a resting tremor that usually goes away when you move. And that is what patients with Parkinson's tend to have. And they have something that is called rigidity or stiffness. And when you look at it and you try to move a joint, it's almost like they have a resistance. And that's the source of actually the fatigue that these patients with Parkinson's have, because when they move the joint, it's almost like they have a 5-pound or a 3-pound weight. So constantly when they're moving, they're exceeding more effort to move, and that's why they get tired and they get fatigued, because they are exceeding some kind of strength to move their joints. And the movements become really slow. And that's part of why their walking gets affected. So they are fighting and resistant when they walk. They have this funky tremor, and they are stiff and slow. And ultimately, and this is a very late manifestation of the disease, they have problems with balance. So unrelated to the slowness and the stiffness and the tremor, they develop problems with balance. Now, balance is a very late manifestation of the disorder. So it takes years. And actually, usually when I see a patient in my office that presents with balance and falls, is not Parkinson. It's usually something else that looks like Parkinson, but not necessarily. Falls is a late manifestation, and we're talking about at least 5 years. Most of the time, it's 10 to 15 years to start having problems with the balance. Now, as I said, they have a lot of other problems, and I'm going to stop a little bit to give you a little bit more idea of what patients with Parkinson have to endure in their life when we talk about other symptoms. Now, the same group of cells that were affected in that little tiny area of the brain, they're affected in the olfactory bulb. What we actually interpret as smell, actually those cells in the olfactory bulb are actually dopaminergic too. So patients with Parkinson's disease, they can't actually smell very well. And one of the things that they notice, even before they develop the tremor and they become slow, they actually lose olfaction. Things don't smell to them. So it's kind of funny because I tend to over-perfume myself sometimes in the morning. I go in a rush and put too much perfume. My wife said, "Don't your patients complain?" I said, "They can't smell me. Don't worry." So she always said, "You put too much." I said, "Don't worry, they can't smell you. Don't worry about that too much." They develop problems with memory or cognition. They have this kind of memory problem, but it's a funny memory problem. And I like to use the term tip of the tongue. The same way they are slowing their movements, they have problems with slowness recalling events. So in a patient with Alzheimer's, they can't store information. They just don't have the gray matter to store that information. Patients with Parkinson, they have normal gray matter, so they store everything. But recalling the information, trying to access that memory area and then bring it back, becomes slow. So they develop this tip of the tongue. Okay, I know I put my keys this time in some place that is not common for me. Where did I get? And they start buzzing around for 30, 40 seconds, and then they say, "Oh, this is where I left it." And they can remember the whole event now, completely the whole trajectory, what they were thinking, where did they put the keys, go ahead and look for them and come and bring them back. But the patient interprets this as memory, and immediately we have the big fear of the Alzheimer's. This is what is happening to me, and the first thing that we need to do is reassure you, no, you remember everything. It just took you longer to recall. And believe it or not, the memory problem gets better with Alzheimer's medications that work in that principle, trying to speed up this process of information recall in patients with Parkinson than it does in Alzheimer's patients. Because if I prescribe an Alzheimer's medication for a patient with Parkinson, they say, "Do you think I have Alzheimer's?" And he says, "No, it just speeds the recall of information the same way it does in Alzheimer's." In your case, it's different. You have the gray matter, so it will work better on you. They have problems with mood because the same dopamine or the same chemical that is lacking in Parkinson patients is implicated in depression. Now, this is not the same depression that you will see in a psychiatric patient. This is more of a mood problem. They don't enjoy things as they used to be. So going to the park was fun. I don't want to go. Or the thing that I see mostly is they stop going to the grandchildren's games. And that is kind of a really big flag. They don't enjoy that. You know, "Why don't you go?" I said, "I don't know, it's the same game." And that's a big flag for me because most grandparents like to go to those games. And even if they don't like the game, they like to see their children do well and have fun. So that is the kind of depression. It's more close to seasonal affective disorder in which they get sad in the winter, but this is a constant sadness that occurs throughout the day. And they don't recognize it as depression because they're not crying, or they still eat and they still have some energy to do things, but they don't enjoy life. They lose the flavor of living and the flavor of enjoying things that are fun. And it's something to keep in mind. And again, it's very responsive as opposed to a psychiatric depression. They usually don't go to a psychiatrist. Psychotherapy has no role in this. This is a chemical imbalance in the sense that really they're lacking a chemical in the brain. And usually treating, they respond pretty good and they are able to return back to, well, behavioral dysfunction. These patients with Parkinson tend to have problems with behavior. And the behavior is actually mostly caused by us because some of the medicines that we use to treat patients overstimulate these receptors. So instead of having a lack of dopamine, when we overstimulate, we can cause behavior. And everybody that has seen advertising hallucinations, oh, I'm going to get hallucinations. Well, the hallucinations in Parkinson are mostly caused by me. I overshoot, or they become oversensitive to the medication and they develop hallucinations. Or they become compulsive, gambling. Or they become obsessed about things. And you have to be careful. It's something that needs to be addressed in the office, and usually we talk about it. Are you obsessed? Are you sometimes feeling of infidelity? Happens in the spouse. And it's something to be concerned about it, but again, it's little things that you don't realize. The other thing that happens is they develop sleep disturbances. The same chemicals makes them restless at night, and they go to sleep and they're tired and they want to fall asleep and they become restless. They need to move and they need to pace. So they go on pace, they feel quiet, they go back to bed, and 5 minutes after they become restless. That lack of dopamine makes them that way. So another thing that they have to endure about this. Same thing that happens with those cells. Believe it or not, the gut also has some little tiny dopaminergic cells, and in that case, when you have the lack of them, you become constipated. And that also is a sense of frustration for them. I can go to the bathroom on time. I have constipation now. Add up to that you have no olfaction. And if you don't smell well, food doesn't taste good. And if food doesn't taste good, you develop something that is called sweet tooth. Because sweetness goes through your tongue, not through the sense of smell. What we interpret as taste is mostly olfaction. That's why people that drink wine, for example, they spend so much time trying to smell it and trying to enjoy the wine. It's because they do that out of the olfaction. So very few things, sweets are one of them, goes through the sense of taste. My wife loves chocolate. That's one of her weaknesses. And again, chocolate is something that is sweet and also goes through the sense of smell. So this patient's even chocolate doesn't taste the same way. But sweetness, cookies, cake, all those things, and those things are very low in fiber. As much as I hate, I still recommend Chinese food because it's high in fiber and it has some sweetness and some different tastes, sweet and sour, and those kind of tastes that are still able to taste good. And actually, it's very difficult to make a piece of broccoli taste good when it doesn't smell at all. So those are one of the ways that I sell the idea of some vegetables to our patients. They actually have a little rash sometimes that is called a seborrheic dermatitis, and it's not dandruff, and it's another source of social disabling. They have this little scale that I usually call the attention to that. And pain, if you actually think about the person carrying a 5-pound weight, and stiff and slow, of course they're going to have pain and stiffness and ache, and something that you actually have to be dealing with. And they have problems with not only constipation, but also they have problems regulating temperature. They just can't. And in this winter, the house is very hot, and in the summer, the house is very cold. They drive their spouses crazy because it goes really hot in the winter, and they keep their houses at 78, 80. And in the winter, very cold. And it's something to keep in mind that they're really not doing that on purpose. So something that is caused by a few little tiny cells can actually affect the patient's life so much. And unless you actually address all those things and bring that to the physician or to the caregivers and possible problems actually can become difficult to manage. Usually, and this is to emphasize, the arms are actually usually affected at first. That's why you see the hand tremors moving. Usually as a presentation, they don't have memory problems to present. There's usually just the word finding, but memory and difficulties thinking and pulling out words is very late. The usual manifestation is the resting tremor is what most people recognize, but believe it or not, you don't need to have tremor to have a diagnosis of Parkinson's disease. You can still have some of the other characteristics and still carry the diagnosis. And actually the hallmark of the disease is when you replace what is lacking, the dopamine, they get better. Just in summary of what we're talking about before I go a little bit about how to manage these patients, it affects about 1 million of patients now in the United States. The lack of dopamine cells in the brain is what causes. It's this very small area of the brain, but it affects. It actually, we don't know exactly why these cells degenerate, but it's probably a combination of factors. We know now by research that we have a genetic predisposition. We have about 12 genes now that we can identify the genetic predisposition of patients. But we need not only that genetic predisposition, something else has to happen in the environment. And that the environmental, we know certain things. Actually, drinking from well water when you were a child can predispose you to Parkinson. Living in an area that has organophosphates, pesticides, can actually predispose you to factors. Living in an area that has exposure to chemicals, factories, can predispose you to Parkinson's. And believe it or not, there was a big study that says that actually cigarette smoking actually prevents you to have Parkinson's disease. It also gives you cancer and all these other things, and heart disease. But unfortunately, that got published, and I always say, it's not worthwhile dying from other conditions, but Parkinson is not as bad as you think compared to the other things that cigarette smoking can give you. Now, the most important things, people think that medications are the clue in treating Parkinson. And in Parkinson's disease, because it affects so many other things, it's just part of this. I spend more time talking to my patients. So actually, believe it or not, education and what I'm doing with you today, kind of explaining the disorder, trying to explain what is ahead, what about when the complications of the disease, the memory component, the depression, the constipation, all these things need to be explained early. Because unless I spend some time with them trying to explain these things, they will not bring it in as a problem in the office, and then it will never be addressed. That's the most important thing. The other thing is support. Here in Reading, it's unbelievable the amount of support that patients with Parkinson have. We have a great rehabilitation services at Reading, but actually even our competition that will be Health South, they actually offer great services for Parkinson's disease. They're actually both accredited in services for Parkinson's disease. A lot of therapists here are certified in Parkinson's disease. We have a home set of services that is certified actually, that will go to your house and offer Parkinson's services as well. So this area is actually very lucky. I came from Wisconsin, that is supposed to be a much more bigger city than this. And actually, I don't think we have as many services in the area for patients with Parkinson's and similar disorders that we have here. The other big component is, and there have been tons of studies, and I'm going to make a big stop. About 15 years ago, there was a friend of mine that is kind of a very frugal woman, works in research, and she spent, and part of the way that people in NIH actually sponsor, get funding for their own research is that they do training of animals for selling, and they support their research based on that. So she had a primate lab in NIH. And part of the research that she was doing, she was training primates for Parkinson research. And then, so you basically go ahead, and she has free-range primates that she sells. And she has other primates that are trained in a treadmill, and basically the primate knows to go into the treadmill and they get fed after they do the exercise, and those are more valuable than that. So you have a whole bunch of graduate students, and they learn to do that, and they train the primates, and they sell them and make money. And then they actually have a model, and they inject some of the primates with a toxin, create Parkinson models in half of the body of the primate, and then they sell it. Which is, if you know this person, her name is Lisa Schumann, she's actually a very frugal woman. And one of the things that she discovered is in the trained primates that she was injecting with toxin required about 100 times more toxin to create the same degree of Parkinson's symptoms as in the non-trained. So she started looking, and she realized that there was a difference in terms of the exercise. And then she actually got interested in trying to do those things. And she actually started doing exercise in the primates that were already with the disease and comparing with the non-trained that they had the disorder. And the exercise-induced primates with the disorder, they did better than, and it's only on primates, and it was only on animals that were exercise-induced. But that created a whole new source of theories about why this happened. Believe it or not, our brains chemically are very similar to rats. And they start looking, they start looking about it's easier and cheaper to actually do dissections in a rat immediately post-exercise. And what happens is that there is a lot post-exercise, there's a lot of nerve growth factors that are the natural protectants that happens in our brain, such as the endorphins happen in exercise in our brain, same as nerve growth factors. And there is a lot of theories now that those nerve growth factors are what is it. So there is a lot of models now looking at exercise. A few weeks ago, there is a new exercise program in town. I'm going to remember the name. It's actually based out of boxing. I'm blocking the name, but it's offered here in town.
Rock Steady Boxing.
Rock Steady Boxing, there you are. Thanks. So now it's offered in town also. This is the new hype in this. We have the big Allowed here in town. We actually have something that is called Power in town. We have a lot of other programs actually that are being offered in terms of those kind of models that are big amplitude exercise-induced models trying to help that and trying to encourage our own endorphins. A few years ago, even before that, somebody in New York looked at a group of people that they were dancers, and I'm talking ballet dancers, that have Parkinson's disease, and the risk of falls in those dancers were actually much less. So they look at conditioning. People look at statistics in China when people don't fall. And for years, we thought that the Chinese don't fall because of diet. They don't fall because of diet. They fall less because they walk, they cycle, and they actually do Tai Chi. So people look at Tai Chi as a model of encouraging balance, and is also actually one of the programs that we have been offering now for patients with Parkinson. That is Tai Chi includes it's actually easier to do than yoga, and encourage balance. It actually is very relaxing. I can't take 5 minutes of yoga, but actually I can do a program with Tai Chi. I found it relaxing and kind of stretches, and you feel good about it at the end. So exercising plays a critical role. And the other part is nutrition. If you have constipation and you don't have modifying your diet to allow for a more diet beneficial for that, if you don't eat enough nutrients, you will have problems with this, because if you don't eat enough meat, or you include B12 and all of the nutrients in your diet that you need, because you basically don't taste food as normal. So you need to start looking at that component of your diet. And you're not going to feel good if you don't do those things. Medications is just part of this whole thing. Actually, the therapy now for Parkinson is complex. We actually just introduced a new concept in our center that's called a multidisciplinary clinic. We have a speech therapy, we have an occupational therapy, we have a physiatrist, we have a physical therapy, and myself actually in a single visit taking care of the patient. and at the end we meet and we create a program for that patient. So it's not that simple anymore, especially when you have complex patients. And it's really interesting, at least for me, the concept. We used to have it, but it's really funny when I put a plan for a patient and then we sit down at the table and somebody said, no, that patient cannot do it. And we have these big discussions in terms of group, how feasible is the care. And we come to a real conclusion instead of what I thought it was going to be my real conclusion. So it puts your humility in my plan of care as well. That is always good to have. I have a team collaboration about how things are. I think that's it for me. I'm going to leave. Yeah. So I'm going to leave this part to questions and answer. I'm sure I'm drawing some questions and some curiosities about the diagnosis.
Is there any value to starting the drug sooner rather than later?
That's actually a very good question. So for years, and I still, if you go into the most common source of this information that is the internet, you will find studies that say that you should spare the medications because in the future, I think 3 years ago, the final publication of a big study that was sponsored by the NIH determined that that's foolish. The more active and the more engaged you remain in your life, the better you are, obviously by that data of the exercise. So nowadays, there's no reason to withhold therapy. Actually, patients that receive early aggressive therapy initially, as you compare them to people that you withhold, they do much better than patients that you hold therapy. Actually, for the last 2.5 years that I have been here, I have devoted my life going to primary care and saying, don't worry, start it. You're not going to hurt your patients. Actually, if you don't start it, you will be hurting your patient. Trying to reverse that, because that philosophy got so embedded in the mentality of physicians that is still, and if you still go into the internet, you will find articles saying that this, you should be sparing the medications. And people read that and they are afraid about it because it takes one article that is false, even if you have 20 others that said start it, and the patients get concerned because you read it in the internet, and that has to be true. Yes?
I'm here because, like you, I have a family genetic history of Parkinson's. Father, grandfather, great-grandfather, all the same line. How do you not fear getting it yourself?
I don't even test myself. I was going to say that because that's another question. We have Parkinson in my family. That's the genetic marker. There's no cure. So why would I worry about what I cannot do? I learned this the hard way. 14 years ago, my wife was climbing in a tree and fell down and she became paralyzed. And that's probably for a lot of people here. That taught me a lesson. I enjoy my life now. Every day I wake up, when I look at her and say, today is the day that I'm going to enjoy my life. I can change that. I cannot change what I have in my genes. I cannot change what is going to happen tomorrow. God was so kind with me that He gave me somebody to look at it and help remind me that every day. It also reminds me that even after disability, there is a life. And when I talk to my patients, I can say, listen, there is a life. Even if you went in a wheelchair, she's happy, she has fun. When I make jokes about my wife when I came here because now my office got changed and she's having lunch with me and she's taking possession of my office. It's fun. I still enjoy her as a wife. And that's the kind of mentality. I can't change that. Now I try to do exercise. I go 3 times a week to the gym. I spend an hour and a half. I talk to the guys for half an hour, drinking coffee, brag about the kids, and complain about the wife for the next half hour, and spend half an hour in the treadmill. and that is what is important for me. It's the fun that I have there, a little exercise, and have fun. If I would be fearful. If I start thinking about it, I would be fearful about it.
Sometimes that's what I do when I think about it.
Yeah. And if I think about it all the time, I will chicken out. I just need to change that.
Right.
I have not even, testing me or not testing me is not going to change my fear. And even if I test that negative, I still can have Parkinson's.
That's true.
So I can't change that. I can change my attitude, and that's what I try to do. I don't know if that helps you, but it helps me.
Yeah.
Yes, I'm sorry.
On the loss of smell, sometimes I don't have as good a nose as my wife, that's for sure. And but sometimes I smell things that are very strong, but I can't identify them. But then they go away real quick. Is this something that happens sometimes to our patients?
You have Parkinson's?
Yes, sir.
It's probably post-nasal drip, to tell you the truth. The strong smells are usually runny nose and post-nasal drip. Is the lack of smell. If you taste or something, it's usually something that drips down and you will feel the smell, and that part is usually not part.
Oh.
It doesn't clear. When you lose, and you will never get it.
Thank you.
Go ahead.
Is there a diagnostic test that shows it, like an MRI or a PET scan?
PET scan helps me. So I'm going to make it, okay. It helps me when I have questions about the diagnosis. In this area, for whatever the reason, there is a high incidence of a lookalike of Parkinson that's called multiple system atrophy. And it's a much different diagnosis. Not everything that looks like Parkinson is Parkinson. It's a much more severe, and actually, as opposed to Parkinson, like you don't die from Parkinson, you die from multiple system atrophy. And
What is that? Multiple system?
so instead of that area of the brain affected, more of those little areas are affected, and the combination of those areas are bad.
What would symptoms of that be? Just generally?
So early falls, as I mentioned, lack of response to the medicines of Parkinson's. They have a depression that is usually not responsive to medication. It's a nightmare. It's a bad disease. And that usually it will require me to get a second opinion that I usually don't. It's one of the few cases I get. If I can't get a second opinion for whatever, I get a PET scan, but it's a combined PET scan. You need to do a fluorodopa and a deoxyglucose. That is the common test that we order here is useless. It's called a DAT scan, and that is a useless test. You need to use a PET scan. And it aids. It's not a definitive diagnosis. We're talking about a $5,000 test.
Wow.
That is a nightmare to call. It still pays, believe it or not. One of the few Medicare things that you can get coverage is that. But they cover 80%, and 80% of a lot is still a lot. Yes?
Are they using deep brain stimulation in Reading yet?
Yeah, we have a big program now.
Because we went through it 10 years ago at University of Pennsylvania. They didn't have anything in Reading at the time.
So Reading does what other hospitals do. We're higher. So Dr. Lawson, that is the neurosurgeon, he came from Johns Hopkins. I came from the University of Wisconsin. I have started doing deep brain stimulation in 1994. So we got hired to come here and develop the program. So our program started pretty early. But that's because we were doing, actually the team that came here is my team. They fly when we have surgeries.
Will the surgeon do battery replacements?
Yeah, he does them. I think some of my patients here have a battery replacement here as well.
Do you have a programmer?
Do I have a programmer?
Mm-hmm.
Yeah, I have like 6 or 7. Yeah, even the surgeon have like 2 or 3 programmers. That's not.
We've been going back and forth to Philadelphia every 6 months for the last 10 years.
You don't need to go there.
You get old when you get in your 80s.
Yes.
How often? It lasts for a long time.
Mm-hmm.
What he's talking about is some symptoms of Parkinson's, you can actually bypass them. Tremors, slowness, the rigidity. with a device in the brain. It's called deep brain stimulation. We started doing them about 2 years ago here. We put a little wire. It's called a brain pacer. That's kind of the equivalent of that. So we put a small wire into the brain and then connect it to a little battery pack, and we can actually turn it on and adjust it. It removes a lot of the symptoms of the disease. It actually makes the disease a lot more tolerable. You don't do anything for the disorder itself because the disease will continue to progress, but things like tremors, some of the rigidity, the amount of medication that you require will be much less, and it makes it a lot easier to handle the disease. Most people get a lot of good quality of years with that. 10, you're counting, huh?
Dr. Perez?
Yes.
I heard that you, in your deep brain stimulation in operations, have advanced beyond what other hospitals are doing during that operation, no halo?
Yeah, so when I came in here, in the University of Wisconsin, we switched to a frameless system. We don't use a frame. So it shortens the length of the surgery. We do the surgery in 2.5 hours, both sides. So instead of putting a frame like you use and immobilize the patient, we put a little plastic cap there that is, the frame is attached to the skull, so the patient during the surgery can move. That allows us to do all the planning of the surgery before the patient goes to the OR. So instead of having the patient 6 hours there in the OR, it becomes 2.5 hours. So it makes a lot different because the patients are awake during the surgery, and not only awake, they don't have any medication. So the way that the patient comes in, they come in the morning, they don't take their pills when they come in, they get the frame set up, and probably around 2 in the afternoon, they're taking the medicines back again. They stay overnight and they go home in the morning.
That's a big difference.
Yeah, it took, that had been for 10 years though, believe it or not. It's kind of new to Reading. It's kind of new to Johns Hopkins that there's still, actually Lawson trying Johns Hopkins, who went back to show them the frameless system now. Because it's a big difference. And it takes, surgeons, once they know the technique, they get used to it. So it takes a while to switch a technique from surgery. What was working for you, you don't want to change. Even though it's a lot of convenience for the patient, it makes a big difference. I remember doing frame surgeries, and that was a nightmare. Patients get tired, they get confused at the end of the day. By the time they go to the unit, it's 6 o'clock in the afternoon, they're tired. I don't want to remember those days.
But it's a lot less, the effect is fantastic. The results are fantastic either way, but the way of the new method is so much less oppressive to the patient.
It allows to, I can say that you had a surgery because you know that. So it allows us to do it in much more older people. Because if you're 76 and you have the surgery, you're going to be beat up. So we used to cut down at around 75. We can do safely a 78-year-old patient without complications now. The oldest I have done is 82, and we got, you get worried at 82, so we cut down at 78, at least in our protocol. Because of, people get confused, they tend to have more complications after. The brain is not as forgiving after 78. There are always exceptions, people that are in very shape, people that have personal reasons, but even at 78, even when you do it, even if you are healthy 78, putting you in 12 hours without medicines, with a frame in the OR, it's very difficult. You will get confused, and you will be 2 or 3 days in the hospital as opposed to keeping you overnight and sending you home.
Right.
No, technology has changed, and the next step is actually without opening your skull.
How about the batteries? They
No
make them
batteries
last-
there.
They make them
So
last
as
a
you
little
get
bit.
older, probably within the next year it's coming to us. So we can actually do lesions. As you get older, we don't want to go into your skull, so we can actually do a high frequency ultrasound lesion in the brain without opening the skull. The only disadvantage to that is you can only use one side. So if you have a lot of tremor, for example, in your right side, we can actually do the surgery in your left side and limit it to one side, but we can control the symptoms in one side in an older person, and it will be in and out surgery. You stay overnight after that, but actually not even in intensive care, you'll stay just in the regular ward. Because we don't open skull, and there's no significant risk. And actually, in all of these surgeries, you're awake, so we know what is happening. I think the worst part of the UMI is the drilling. Go ahead.
Is there anything with music therapy that helps?
So dancing is the other, people are very smart here. So dancing is actually one thing. People have looked at dancing as a main mode of things. Today is actually my dancing night. Most of my patients go to dance on Thursday because I encourage them to go. There is a place in town, I don't want to go ahead and advertise, that offers a buffet, a dancing lesson for $12. And it was, so I go there and see some of my patients there because I encourage them to go there. And it's kind of fun. It's one of the few things that people can do on things. Balance and dancing is goal. Why is so important dancing? In my practice, is great. You do it as a couple. That's the first thing. It's a dancing lesson. So you go and meet other people that are not getting therapy. You're going there to have fun. You meet other couples. That creates communication with other people. Usually, you get it in the afternoon. They meet up for coffee, for dinner. You make out of a couples therapy. So not only you get the exercise, the coordination, but actually you get some socialization as well. The rhythm and the learning of the new skill is actually what you're getting at it. I had a patient that complained after 7 years that he was not getting more than intermediate in dancing. He was losing his time, and I said, have you ever had a fall? Are you still walking normally? So that's what you're getting. You're maintaining your function. And then he realized that he was really getting a lot of things. But actually, I think you get more about the socialization part. Funny story, in Wisconsin, there was Madison is a very liberal city, much more than Reading. And so there was a gay bar that actually offers a program for dancing for students. So I started sending all my patients there, but I've never been there. I said, well, there's this program there that they offer. So finally, one of my patients said, well, they have this show, you should go there. And I didn't realize that they were going to ask for IDs. So I go there and go into this gay bar and I show this my ID and I said, are you Dr. Perez? And I said, yes. And he goes, hey, Pete, this is Dr. Perez, the guy that is sending all the old guys on Thursday. I look back at the guy and I said, do you mind? I'm sorry. I said, no, we love it. They're really part of the group. They have a ball here. We have fun with them. And it's part of a reaching out program, so we love it. But I was so embarrassed. And I said, but they knew me already because everybody said, the doctor sent me here. So it's one of the things that you learn. So now I'm trying to be more candid about sending people there. And thank God I moved. Go ahead.
What aspect of Parkinson's, either in progression or symptom or sign, makes you want to recommend deep brain stimulation?
Well, not because of the tremor that doesn't get better and is disabling. People that take medication every 2 to 3 hours and live around their medications. Some patients develop abnormal movements that we call dyskinesias, the side effects. People that develop obsessive compulsive behavior or hallucinations that are due to the medications. Rather than trying to block the hallucination like the advertising does, it's probably send them to surgery. the cost of the, and I'm going to say this because I'm exploding to say it, the cost of the medication for hallucinations that they are advertising is around $26,000 a year. The cost of the surgery is around $30,000 one time. So the
Won't help
insurance,
stiffness or anything like that.
huh?
It won't help the stiffness or the breathing.
And it doesn't help the stiffness, and you still have to deal with the side effect of the medication. Surgery is one time, and every 5 years you pay, I think, $15,000 for the battery or something. It becomes a deal for the insurance company to have the surgery. It becomes a deal for the patient. So everybody wins this time. Before all these expensive medications came into the, yeah, we had a lot of problems getting justification for the surgery. Some of the medicines for Parkinson's are really getting expensive. Some of them, you're talking about the cost of a year of a patient, fancy cost for around $75,000 a year.
And
Yes.
what part of that does Medicare pay or insurance?
Oh, the surgery?
Yeah.
If you have a secondary, pretty much it covers all the surgery.
Okay,
It gets covered most of the time.
okay,
Medicare, if you have only Medicare, is 20%, 80%.
okay.
Most people have, and it's approved. Yeah, and it's really. Yes.
Is the stiffness problems and lack of dexterity can that be reversed by excessive or strong exercise programs? Can you turn them around?
Yes and no. Gross motor skills, yes. One of the things that we never get is handwriting, guitar playing. I have patients that, they used to play guitar or drummers. There are certain skills, and the handwriting can in some therapy forms, believe it or not, speech therapy really helps handwriting. Don't ask me how, but if you take a patient that have an intensive course of speech therapy and you examine the handwriting improve after the speech therapy. Funny, but it does. Same as some of the components of big M. But it would never be the same beautiful handwriting. I have patients that come in and they have that beautiful handwriting. It gets better, but not. That's the type of skill that you want, drummer or woodwork.
He's a guitar player.
Yeah, that's a tough one.
I just want to be able to do fine work with my hands, like I fix things. And I know how to fix them, but I can't manipulate them.
Some of the, screwdrivers you can get, there are some, but there are some skills, guitar playing, violin, those are much more difficult, especially.
I find that things that I do constantly, like I can still drive a car quite fine, but some things that I slacked off with, like I don't write every day, and so I feel like I shot myself in the foot by not keeping the skills current, like I have with driving. It was kind of an accident that happened because I drive every day.
Well, driving is a gross motor skill, meaning there's not a lot of fine dexterity movement. It's those kind of movements. It's piano playing.
Well, but I find myself to be a safe driver, and so and that requires reaction time and speed to move your leg and hit the brake.
That's reaction time, no fine motor skill.
Okay, so maybe I misunderstand some of those things, but I guess
Fine motor skill is this kind of alternating rapid movements that you'll need to play guitar, to play the drums, the coordination, the drumming, the keeping the beat.
So if I'd have done those exercises every day since I've been diagnosed,
It would have been taking you longer to lose them. You will have lost them, but it will have taken longer.
Eventually they go down the drain.
Yeah.
Oh, all right, that makes sense. Eventually we're going to die anyhow.
We all are. Yes.
Does research indicate that there's any cause for hope for a cure?
So a few years ago, I heard that it will come in 10 years. There's a lot of retroviral studies, meaning that you can actually, there was so much emphasis about fetal tissue transplant, and I heard it all. And without going into a lot of controversy, fetal tissue is a dead subject because now we can create stem cells from your own mouth. And we can put those cells there, but we cannot make them create the proper connections. And that's the point. We can actually put cells in your brain, put them there, they can make dopamine, but they cannot create the sprouting that necessary, the connection. We cannot make them grow in the right direction. Some people in England are looking at those growth factors to see if we can make them sprout again. But the real thing is we'd be trying to just go ahead before the cells die and actually trying to make those cells before they die to reproduce. But once you have the disorder advanced, then it's going to be the big problem. And people always ask me, would there be a cure? Yes. But for people that have the disease in milder forms, you can actually inject those cells or inject you with this virus that actually will make those cells stop dying. For people that lost a lot of cells, that's a different story because those cells are dead, and trying to say what you have, it would arrest the disease, but you still have some deficits. And we're closer to that. We're closer to be able to arrest the disease, and the question is, whatever you have, can we arrest it at that stage? And that's the question. As time passes on, you will have more deficits, and the more it takes to get there, the longer it takes, the more deficit people will have, or patients will have. Yes?
How do you judge stages?
I don't judge them. Patients do have stages. So stage 0 is no disease. Stage 1 is symptoms in 1. Stage 1.5 is one side of the face. Stage 2 is disease in both sides. Stage 2.5 is some mild problems with balance in both sides. And stage 3 is when I put you back, you will continue to take steps. Stage 3, you will fall. Stage 4, you will need a walker to be able to continue to ambulate, and stage 5, you're bedridden, or need help to walk with somebody.
So Parkinson's doesn't kill you.
No. The life expectancy.
Does staying in the bed kill you?
Yes.
Okay.
Falls kill my patients, not Parkinson's.
Falls.
Yeah. That's the first question that my nurse asks my patients when they come in. Have you had any falls? Big red mark. Most of my life is spent trying to avoid falls. Because that's it. A walker is the biggest helper that I have in my career. Cane, proper shoe attire, having a house that doesn't have area rugs because they can trip. I hate flip-flops. I hate sandals. I actually asked my wife to get pictures of proper shoes that women can use in the summer that are pretty and they're safe for them to walk, so my patient will not have, because women love sandals in the summer. I can't sell the idea of a shoe that is not pretty and summer-like.
So I can see why you don't like flip-flops. What's wrong with sandals?
Sandals, if the sandal doesn't have a strap on the back that retain the movement of the shoe when you walk, it's the same as a flip-flop. So it is. So every time you start doing it, and I need to be. Believe it or not, part of my life is being a good salesman. I need to sell the idea. I need to sell the idea of fall prevention. I need to sell the idea that when they come into the office, you need to be doing exercise. I need to sell the idea that the medications are going to work. I need to sell the idea, please don't read the paper that the pharmacists give you. If you have side effects, these are the side effects that you have been looking for, not what the pharmacist said, because even if you look at the side effect of penicillin, it's 2 lines. And more people die from penicillin than from any other drug that we have now. Penicillin allergy is one of the reasons that people lose all the time, and yet I have people begging for penicillin. I have a cold, I want my penicillin. They don't check the side effects, but it's just seeing where the risks are.
How often do you see cessation?
Very, very late in the disease. Very, very I seldom see patients at that stage anymore. The people that I see with dysphagia are the multi-system atrophy, the Parkinson plus syndromes, although they look alike. All these can be managed. And the message that I send is enjoy life now. It's fun. This is where we are. And every day is a good day. Not from my own experience, but from my own life, my own family. It's a gift. We see it, I had a great job. Because I get reminded of all this every single day. And we complain about so little things, about so petty things, and we never learn to appreciate this. And I see people, and I just came from the hospital because I'm doing general neurology. About 6 weeks a year I do general neurology, and I saw this lady waiting for having fun in her retirement, and she has a brain tumor. And she waited and never had fun. And, the time to have fun is now. And the time to be grateful is now. It's the time to be happy is now. The time to forgive is now. I'm sounding more like you now, but it's true. I don't know.
Taking notes.
I see it, but I'm seeing it from another perspective, from the other side, when you and lost, when everybody's at the end. And I said, no, do it now. Parkinson is not the end. Just another chance of fighting again and having fun. If you let a disease beat you up, that's terrible. I see more disability out for rheumatoid arthritis, and people are not afraid. If I tell a patient you have diabetes at the age of 60, I will be shortening their lifespan. Yet people are not afraid of it. Take it for granted. Yet I will be shortening their lifespan and giving them probably much more disability in the long run. So it depends on how we see life. This is something that you can manage, and I'm not saying this. I told you all the problems that they have, but these are manageable. And you can go ahead and fight it. And it's kind of fun when I see my patients and I say, well, I got the constipation now beat. And now I'm going to do the mood part. And I do exercise. And I'm going to go ahead and now I can enjoy my grandchildren. And I can do this. And I can do that. And I can move. And I can go and have dinner. I see heroes out there every day. I see a lot of what I know in my life. People taught me. The other day I saw a patient and I said, well, how do you have problems? One of the questions that I asked, you have problems eating with a knife and a fork. And I said, I got solved this. And the guy went to actually TJ Maxx and got this funky knife that is self-sharpening every time he gets out of the sleeve. And it's a very, very sharp knife. And when he goes to a restaurant, he gets it out of his wife's purse, he cuts his meat all there, cleans it up with a napkin, gives it back to his wife, and then he eats his steak. He doesn't tell anybody. He's prepared for that. But and he feels happy. He paid $8 for that knife, and it's giving him every single content dinner that he can imagine for $8. And you have to see this kind of little guy there, happy to show me that knife. How he beat that disability. But everything is in the attitude. I learned so much about medical marijuana these days, thanks to the States. So the other day, an 82-year-old woman, and she comes in very happy. She had mild Parkinson's, but she came in and I said, well, you have this, and she showed me her 3 little inhalers with marijuana, the THC, whatever that is. Because I don't know anything about these things. I'm naive to all these things. And she said, well, this one is for, and she has them labeled, the daughter wrote down for what they are. And one is to go to sleep, and one is when she feels doesn't have enough appetite to increase her appetite, and then is when she has pain, she has another one. And she has them labeled for them, and she said, well, it's kind of funny, when I go to the store, I have to show my ID. They don't let you go into the store without your ID. So she enters and she feels privileged, and then everybody there is very helpful. And she has all these kind of names, Mary whatever, all these things. But you may an 82-year-old woman come into the office and say, oh, this is how I'm beating my disease, and you're my 3 inhaler. And I say, well, don't you get confused? So my daughter labeled them. See, you know, and she has them all labeled. Just having the ball of her life. At 82-year-old, we have 3 little inhalers of THC. And more glory to her. Have fun, and I'm opposed to all that, believe it or not, but if she's having fun at 82 and that's the way she's enjoying life, God will have more glory to her, more fun to her. I'm not going to feed her. Guys, so get something. It's a difficult disease. It's a disease that affects you every single aspect of life, and there is hope, and there is a lot of things, and there are so many things we can do now. So the message is, this is a disease. There is fear to it. But the fear and how you fight it is every day, every single time in your hands. So thank you for, yeah.
Are there support groups in the area?
Oh yeah, many support groups in the area. We have one in the rehabilitation hospital. We have one in Phoebe. We have more than that. We have like 4 support groups, and somebody called my office, we have a list of all the support groups there. But I know we have one in Phoebe that is brand new, that meets every other week. We have one here that is in every week, every month, every Monday is in the afternoon at 3:30. One in Muhlenberg, but I don't know the address of that one.
That's for the spouses.
You know, all the things that you have on with that list. I knew you got me with that one. There were 2 things. I just got and the release of TV, medical doctors for marijuana. It's always a big question. I forgot about that. Good. Thank you for having me.